Good afternoon. Welcome to Clinical Case Series. My name is Dr. Olutayo Sogunro, and this is General Surgery Case number 4. We will begin with the history of present illness, a case presentation, followed by a clinical discussion. This is a 40-year-old male with a chief complaint of diffuse abdominal pain. He has a 3-day history of diffuse abdominal pain and constipation. His signs and symptoms include nausea and vomiting. His past medical history is significant for chronic back pain. His past surgical history is significant for an exploratory laparotomy with a right hemicolectomy for a gunshot wound to the abdomen 10 years ago. His family history is unremarkable. His social history is positive for occasional alcohol use, positive for illicit drug use, but negative for tobacco use. He is not on any medications, and he has no known drug allergies. What would you like to do next? His physical exam. His vital signs are within normal limits. He is alert and oriented. Heart, regular rate and rhythm, lungs clear auscultation. His abdomen is soft, non-distended, but diffusely tender. It's worse in the right and left upper quadrants. No rebound tenderness or signs of peritonitis. He does have a large midline scar from his previous laparotomy. No deformities or edema in the extremities. Laboratory work. As you can see, his labs were relatively unremarkable. Now what would you like to do? How about get some imaging? Here's his abdominal x-ray, and here's a CT scan of the abdomen and pelvis. Do you notice anything? How about now? What is your differential diagnosis now? If you guessed small bowel obstruction, you were right. Now what would you like to do? So the patient was managed conservatively for a few days and failed to improve. He had multiple serial abdominal exams and nasogastric tube and did not improve. Ultimately, he failed conservative management. He had an exploratory laparotomy, an extensive lysis of adhesions, and he was found to have a small bowel obstruction due to extensive adhesions from previous surgery. Postoperatively, he was managed on the medical surgical floor. The first few days, he had his nasogastric tube in place, pain was controlled, and we were awaiting bowel function. On post-op day number 4, he started passing flatus, and his NG tube was removed, and he was started on a clear liquid diet. Post-op day number 5 through 6, he started ambulating more, tolerating his diet, and still awaiting his bowel movement. By post-op day number 7, he was doing great on a low-residue diet, ambulating, and had had his bowel movement, and was safe for discharge. Now let's have a clinical discussion about small bowel obstructions. A small bowel obstruction is the interruption of the normal flow of intraluminal contents. Most common causes are adhesions, hernias, or malignancy, what I like to call ABCs, adhesions, bulges, or cancer. The small bowel is involved in approximately 80% of cases of mechanical intestinal obstruction. Small bowel obstructions can be functional due to dysfunctional peristalsis, also known as ileus, or mechanical. Mechanical small bowel obstruction is caused by intraluminal or extraluminal mechanical compression. In developed countries, adhesions is the most common cause, followed by hernias, malignancies, and various other infectious and inflammatory disorders. Epidemiology. Small bowel obstructions are common surgical causes of abdominal pain. They account for 2 to 4% of emergency department visits, approximately 15% of hospital admissions, and 20% of emergency surgical operations for abdominal pain. That is more than 300,000 operations annually for small bowel obstructions in the United States. The male to female prevalence is about equal. The average onset is age 64, and only about 20 to 30% of small bowel obstructions actually undergo surgical intervention. Pathophysiology. Mechanical obstruction leads to proximal distension and distal decompression of the bowel. This leads to wall edema and fluid sequestration in the bowel lumen and third spaces, such as the peritoneal cavity. Excessive bowel dilation from twisting of the bowel or of the bowel mesentery or from adhesions can lead to compromised intramural small intestinal vessels, leading to decreased perfusion and therefore ischemia and perforation. Risk factors include previous surgery, which can cause adhesions, abdominal wall or groin hernias, inflammatory bowel disease, a history of neoplasm or current neoplasm, or previous radiation. Small bowel obstructions present with signs and symptoms of nausea, vomiting, and crampy abdominal pain, and obstipation. Workup and diagnosis. This includes laboratory work and imaging. Labs such as a CBC, a BMP, and a lactic acid can be very helpful. Oftentimes, in these patients, you'll find an electrolyte abnormality, such as that in sodium or potassium. Imaging includes abdominal x rays, a CT scan, and a small bowel follow through. An abdominal x ray should be the initial imaging modality in a patient you suspect has a small bowel obstruction. It will show you distension of the bowel, as well as air fluid levels, and you can also find pneumoperitoneum in the case of perforation. The sensitivity and specificity for plain film in small bowel obstruction is up to 83%. The findings on plain film consistent with the small bowel obstruction include air fluid levels, bowel dilation, and a gasless abdomen. Generally, for bowel dilation, it is important to remember the 369 rule. The diameter of the middle portion of the small bowel, or jejunum, will be approximately 3 centimeters. The middle of the large bowel, the transverse colon, will be approximately 6 centimeters, and the cecum will be approximately 9 centimeters. Anything larger than these usually indicate dilation. A CT scan of the abdomen pelvis with IV and oral contrast should be obtained. It is both sensitive and specific and can show you not only the small bowel obstruction, but also the complications of a small bowel obstruction. If a patient is suspected to have a complete small bowel obstruction based on clinical evaluation, you should avoid oral contrast because this may induce further discomfort or complications. Additional findings on abdominal CT consistent with a diagnosis of small bowel obstruction include bowel wall thickening greater than 3 millimeters, a submucosal edema or hemorrhage, and mesenteric edema and ascites. An additional imaging modality is a small bowel follow through. It is performed by the ingestion of oral contrast, either oral or via nasogastric tube, and an evaluation with serial x rays. It can be both diagnostic and therapeutic. It looks for the progression of the contrast through the GI tract. Failure of the contrast to reach the colon within 24 hours should influence, but not necessarily dictate, a decision to possibly operate on the patient because they do have a true small bowel obstruction. The patient in this case also received a small bowel follow through, in which he did not have progression of the contrast into the colon in 24 hours, which is one of the reasons we decided to operate. Here is some imaging, a CT scan of the abdomen pelvis. On the left side of your screen, you can see these air fluid levels in the small bowel. And on the right side, you can see some mesenteric edema, some distended bowel loops, as well as a thickened bowel wall. Here's the patient's small bowel follow through. As you can see in the picture on your left, you see the contrast in his stomach shortly after ingestion. After 24 hours, the contrast was still here in the left upper quadrant, did not pass into the colon. He failed his small bowel follow through and was ultimately taken to the operating room because he had a persistent high grade small bowel obstruction. Of note, those small metallic fragments that you see are from previous bullet fragments from his previous gunshot wound. Again, here's his small bowel follow through with minimal progression of the contrast. Majority of small bowel obstructions resolve without surgical intervention. Approximately 70 to 80% of them resolve on their own. Initial medical management includes keeping the patient NPO, IV fluid resuscitation, electrolyte repletion such as potassium, nasogastric tube decompression, and abdominal exams with a surgical consultation. Patients with small bowel obstructions can have severe volume depletion. Metabolic acidosis or alkalosis can occur, and severe electrolyte abnormalities. This is particularly true for patients with copious emesis from the obstruction. Those with symptoms lasting several days prior to presentation, or obstruction that causes large volume intraluminal fluid sequestration can cause this. Upon admission, isotonic crystalloids such as lactated ringers or normal saline may be appropriate for initial intravenous fluid therapy if the patient is severely dehydrated. When to go from medical to surgical treatment is really based on clinical findings. It is widely accepted that stable patients with a small bowel obstruction may undergo initial non-operative management as long as there is no complication, for example, bowel ischemia, necrosis, or perforation. Current guidelines suggest that in the absence of clinical deterioration, most patients with adhesive small bowel obstruction should undergo surgery after 3 to 5 days of unsuccessful non operative management. Again, this is all dependent on the clinical situation. The need for immediate surgery based on abdominal CT scan findings include bowel ischemia, necrosis, perforation, closed loop obstructions, such as a volvulus, an acute incarcerated hernia, intussusception, gallstone ileus, foreign body ingestion, and others. Clinically, a patient with peritoneal signs and persistent alteration in vital signs, such as fever, tachycardia, and hypotension, may require immediate surgical intervention. Even when immediate surgery is needed, adequate resuscitation should be attempted prior to surgery. Surgery involves a diagnostic laparoscopy or an exploratory laparotomy to evaluate the cause of the adhesions. Oftentimes, you are lysing adhesions, repairing a hernia, or removing a mass or tumor that could be causing the obstruction. That's it. Thank you very much for watching. I hope you learned more about small bowel obstructions. Please contact me with any questions. Thanks for watching.